Good afternoon, everybody. I'm watching the number of participants roar up now that we have opened the broadcast. We're expecting quite a few people, so we're going to wait just a minute or two to make sure that everybody is on before we get started. We're up to about closing in on 200 right now. We're expecting close to 500, I believe, somewhere in the high 400s. So we'll just wait just a minute and then we will get started. It is now just 2 minutes after 1. These numbers are still climbing, so I'm going to give it another minute or two, and then we will get started. We know certainly that not everybody that registers shows up, but people are still entering the room, so just bear with us. Oh, hello, Whitney. All right, I think we're going to go ahead and get started. This introduction is a little bit lengthy with logistics and other details, so there still will be time for people to join before Rebecca Siegel begins her presentation. So, welcome everyone. Good afternoon. My name is Bob Smith. I'm the Senior Vice President of Cancer Screening at the ACS, and I'm also the co-chair of the National Colorectal Cancer Roundtable. I want to thank all of you for joining. It's quite a crowd we have here. It's an interesting topic, and we have one of the, internationally, one of our top experts that's going to deliver this. The purpose of today's webinar is to basically take a close look at what the data tell us about the incidence of colorectal cancer, incidence, mortality, and screening rates, but in particular, where there's going to be a strong emphasis on the fact that the incidence is shifting to younger adults. These findings that you'll be hearing today were published in the March issue of CA, Colorectal Cancer Statistics 2020. I remind everybody on the call that that is an open access article. So if your interest is stimulated further, we will be sending out these materials the materials will be available to everybody, but I'd strongly encourage you to download the article and read it at your leisure. Next slide. And this is actually the article, so we breezed right back that cue. Let's go to the next slide, Becky. And I just want to show you, this is really interesting because data are now just starting to show up about the impact of the pandemic on cancer screening, and not just colorectal cancer screening, but all cancer screening. This particular graph is a little hard to sort out, but what you see in these long lines that basically this is from Epic Health Research Network, and it sort of shows the routine count of cancer screening month by month over the years 2017, 18, and 2019. So you see as they follow a pretty common and flat trend, and you can see from the x-axis the numbers that they would normally record month by month. And then you see in what looks to be these little waterfalls is in effect what's happened as the health resources have been repurposed, as elective services have been shut down. We have had a startling and precipitous drop in cancer screening to the point that it's in, not even over 1,000 in each instance. Next slide. And what we're expecting to see is consequences of this. In other words, even though this has been just for a few months, we expect that people will take a while to get back into cancer screening. Some people may not return to cancer screening. People who are at higher risk may not be screened in time for their unique circumstances. And one publication recently estimated that we are at risk for up to 18,000 missed or delayed colorectal cancer diagnoses in early March to early June as a result of the upsetting of the normal rhythms of routine screening. The incidence, mortality, and screening findings that you'll hear about today were, of course, captured before the pandemic, and so they do not reflect any of those recent trends. But as we go forward, we're going to be very interested in what's happening with these data and what's going to be the consequences as a result of these delays in screening and potentially delays in diagnosis. So today we're fortunate to hear from the lead author of the Colorectal Cancer Statistics, Rebecca Siegel, who is Scientific Director of Surveillance Research at the ACS. For years, Becky has led numerous sentinel publications on cancer incidence and mortality, and she is perhaps best known for her more recent contributions on our understanding of early onset colorectal cancer. She is a leading scientist in this area, and she's an outstanding speaker, so we're very fortunate to have her. Let me go through a little housekeeping before we get started. Let me change that slide, all right. We are recording today's webinar, so the replay and speaker slides will be shared with all of you and posted on the Roundtable website within a couple of days, and we will notify you when the full slide set and recordings are available. And of course, you are free to share these with your colleagues. Also, because of the large number of participants, all participants are muted on today's webinar, but we will have an opportunity for questions and answers, which you can post to the Q&A box throughout the webinar. I will be monitoring those, and then I will be relaying those to Becky when we have the Q&A period. And finally, we're always trying to improve these webinars, and especially because this is going to be the new normal for some time, you'll be receiving an email with a survey link, and please, please, please take a few minutes to give us a very honest response about how well you think we did, because we benefit from your feedback. With that, I'm pleased to turn the webinar over to Becky. Becky, take it away.
Okay, thank you, Bob. Good afternoon, everyone. And thank you to Bob and Emily for inviting me to present on findings from the Colorectal Cancer Statistics 2020 article that, as Bob said, was published in March. This article, along with its consumer-friendly companion, Colorectal Cancer Facts and Figures, is updated every 3 years by ACS to provide a comprehensive view into contemporary colorectal cancer occurrence in the US. And this year, we were fortunate to have additional expertise from colleagues at Dartmouth and Sloan Kettering. All of the statistics in the article are calculated from population-based data from national surveillance systems like NCI's SEER registries and CDC's National Program of Cancer Registries. The North American Association of Central Cancer Registries, or NACER, is an umbrella organization that works to enhance the use of cancer registry data by disseminating high-quality combined SEER and MPCR data that result in contemporary cancer occurrence for 95% of the population. And those are the data on which the trends that I'll show you are based. For mortality, complete population coverage has been available long-term from the National Center for Health Statistics. And our screening data are from the National Health Interview Survey at the national level and from the Behavioral Risk Factor Surveillance Survey, or BRFSS, for states. In 2020, there will be about 148,000 new cases of colorectal cancer diagnosed in the US and about 53,000 deaths from the disease. Slightly over half of cases and more than 2/3 of deaths will occur in adults 65 and older. And about 12% of new cases in 2020 will be in people under 50. The overall colorectal cancer incidence rate is about 39 per 100,000 individuals, but of course varies widely by age, racial ethnic group, and sex. Here we have sex-specific rates for incidence to the left of the vertical line and mortality to the right. The incidence rate is 30% higher in men than in women, and the mortality rate is 40% higher in men. The incidence disparity is larger for rectal cancer than for colon cancer, with rectal cancer rates about 60% higher in men than in women. Sex disparities also vary by age, and this chart shows the male-female incidence rate ratio by age at diagnosis. Under age 45, incidence is fairly comparable in men and women, whereas for those in their 60s, for example, rates are 50% higher in men. And reasons for this sex disparity aren't completely understood, but probably relate to differences in exposure to behavioral risk factors and perhaps differences in sex hormone exposures. The higher rates in women among those in their 20s that you might notice on the far left reflect a disproportionate number of appendiceal cancers, which are generally included in colorectal cancer rates, although they are excluded from all of the trends that I'm going to show you. And I'll talk more about appendiceal cancer and its influence on colorectal cancer rates right now at the end of the presentation. Of course, in both men and women, incidence rates increase with age, and rates are highest in those 85 and older. And this is somewhat different than the age curve for other cancers like breast cancer that drops off for octogenarians. A caveat to this, shown in the smaller figure, is people in their early 50s who are initiating screening, because rates are actually higher in people 50 to 51 than in those 52 to 54 because of screening initiation and the detection of prevalent asymptomatic tumors. We know that this is a screening effect because it's absent in rates prior to widespread screening in the 1970s. And this finding was also recently published by Carlitz and colleagues, who note the opportunity for earlier detection and maybe even some cancer prevention with screening at 45 for those at average risk, as the ACS recently recommended in their guidelines. There continue to be large disparities in colorectal cancer occurrence between racial and ethnic groups, and this figure shows contemporary incidence rates, which are highest in Blacks, shown in red, and lowest in Asian Americans, shown in forest green. Rates in Black men and women are about 20% higher than those in whites. However, within these broad population groups, rates are by far the highest in the US among Alaska Natives, who are shown in dark purple in this inset. and separate from American Indians. Both incidence and mortality in Alaska Natives are double those in Blacks, and mortality in Alaska Natives is almost 3 times higher than in whites, 40 per 100,000 versus 14. Reasons for the high burden in Alaska Natives remain unknown, but probably relate to differences in exposures, like a diet high in animal fat and low in fruits and vegetables, high rates of smoking, obesity, and diabetes, and possibly H. pylori infection. Exacerbating this issue, of course, is the limited capacity for screening and colonoscopy follow-up because of both limited resources within the Indian Health Service and geographic barriers to care in much of Alaska. And notably, American Indians and Alaska Natives are the only racial and ethnic group for which colorectal cancer mortality rates are not declining. Disparities in mortality usually surpass those for incidence because of less access to care among minority and low-income groups, resulting in delays in diagnosis, which are most common among Black patients. For example, 1 in 4 Black patients is diagnosed with metastatic disease compared to 1 in 5 white patients. And this, of course, translates to lower overall survival among Blacks. 60% of Black patients survive 5 years beyond diagnosis compared to 2/3 of whites. However, survival lags in Blacks at every stage of diagnosis, with the largest difference for regional stage disease. Notably, when cancer is diagnosed at a localized stage and treatment is more straightforward, the 5-year survival is similar across all of these population groups. More than half of the Black-white survival disparity is estimated to be due to differences in insurance coverage, as a recent study reported. Now we'll turn to trends in incidence and mortality. This figure shows long-term trends by sex for all ages and race ethnicities combined. Rates continue to decline overall, although reductions in both incidence and mortality have slowed from about 3% to 4% per year during the 2000s to about 1.5% per year over the past 5 data years. The deceleration has occurred more so among whites than among Blacks in recent years. And this has actually resulted in a slight narrowing of the Black-white mortality gap. The figure on the right shows the temporal trend in the Black-white mortality rate ratio, which has dropped to 34% in 2017 from a peak of almost 50% in 2005. The Black-white disparity is the result of differences in both risk factor prevalence and healthcare access driven by disproportionate poverty among Blacks. Some good news is that Blacks had the largest mortality declines over the past decade of any racial and ethnic group, and also had the only declining trend in mortality in people under 50. Slowing progress in incidence and mortality probably reflects increasing rates in young age groups, along with reductions in both the rate of first-time colonoscopy screening and screening overall in people 50 and older. And this slide shows declining incidence alongside colonoscopy use in people 50 and older. Colonoscopy uptake surged from 20% in 2000 to 56% in 2010, largely because of Medicare expansion of coverage for colonoscopy to all individuals in 2001. Rates have climbed much more slowly since 2010. And as this audience knows well, up-to-date screening varies widely between population groups and will probably be even more affected, as Bob mentioned, because of the pandemic. People with the lowest rates as of 2018 were those younger than 55, minorities, especially Asians, and those with less than a high school education or who are uninsured or Medicare insured. Screening also varies widely by state, with the highest rates shown here in gray and the lowest rates in dark green. Screening prevalence is the lowest in the West and Midwest and highest in the Northeast, ranging from 60% in Wyoming to 76% in Massachusetts. Among individuals younger than the traditional screening age, so under age 50, often referred to as early onset colorectal cancer, incidence rates, which are shown on the left, have been increasing since the mid-1990s, and mortality rates, shown on the right, have been increasing since the mid-2000s. The pace of the increase is similar in men and women for incidence, but is slightly steeper among men for mortality, which may reflect differences in stage at diagnosis. 36% of women under 50 are diagnosed at a localized stage disease compared to 31% of men. Part of the reason that the mortality trend in those under 50 is basically keeping pace with incidence is because late stage diagnosis is a hallmark of early onset colorectal cancer. This figure shows trends by stage at diagnosis. During the past decade, rising incidence has been confined to regional and distant stage disease, with rates of localized stage diagnoses stable since 2006. And this chart shows stage at diagnosis by age. Patients under 50, shown here in red, are much more likely to be diagnosed at an advanced stage than their older counterparts, with 1 in 4 diagnosed with metastatic disease compared to 1 in 5 patients 65 and older. Of course, this is partly because of screening in older adults, but even after accounting for screening, young patients are 40% more likely to be diagnosed with late stage, mostly because of avoidable delays in diagnosis. For example, one study found a median time from onset of rectal cancer symptoms to treatment of 217 days in patients under 50 compared to 29.5 days in patients 50 and over. The largest contributor to this age disparity is a longer time between onset of symptoms and initial provider visit among young patients. This slide shows trends in incidence under 50 by tumor subsite. A new finding in this paper was that these nationally representative data show that during the most recent 5 data years, so from 2012 to 2016, rates under 50 increased by about 2% per year for tumors in the proximal colon, as well as for those in the distal colon and rectum. And this contrasts with earlier years when the increase was very much driven by rectal tumors, as you can see by the steeper slope for rectal cancer here. These next 2 slides show trends in incidence under 50 by racial and ethnic group. The most rapid increases are in non-Hispanic whites and American Indians and Alaska Natives, about 2% per year over the past 2 decades. There's also been a small but statistically significant increase in Blacks and Asians under 50 by about 0.5% per year, although this is confined to tumors developing in the rectum. Rates of colon cancer, specifically in Blacks and Asians under 50, are stable. Among Hispanics, rates increased in the late 1990s and then remained stable, except for an uptick in the past 2 data years that wasn't statistically significant. Not only are young adults increasingly diagnosed with colorectal cancer, but generations who first experienced this excess risk are carrying it with them as they age, and this is referred to as a birth cohort effect. This slide shows incidence and mortality patterns in individuals 50 to 64, which have begun to change in recent years because of this strong birth cohort effect. On the left, incidence rates in people 50 to 64 increased by a statistically significant 1% per year from 2011 to 2016 after declining by 2 to 3% per year in the previous decade. And similarly on the right, mortality rates have the decline in mortality rates has decelerated from 3% per year down to 0.6% per year. The increase in this age group notably is confined to non-Hispanic whites and American Indians and Alaskan, which makes sense because, as we just saw, those are the groups with the steepest increase under 50. These patterns are in contrast to trends among individuals 65 and older shown here, which are driving the overall trends. Both incidence and mortality continue to decline rapidly in people 65 and older by about 3% annually in recent years, although this is slightly slower decline than in the previous decade. Declining incidence in older age groups coinciding with increasing rates in younger individuals is rapidly shifting the colorectal cancer patient population younger. The median age at diagnosis shifted from 72 at the turn of the century to 66 in 2015-2016 in SEER data. And it's even younger for rectal cancer, with half of patients diagnosed with rectal cancer are 63 or younger. And as you'll recall from the first slide showing the 2020 estimates, we anticipate the median age to be even younger by 2020. This shift, as well as other data published in the past 2 years, supports lowering the age to begin screening, as ACS did, to 45. Although individuals under 50 only represent 12% of the newly diagnosed colorectal cancer patients, the actual burden among young adults is surprisingly high. In 2020, about 18,000 people in the US who are in their 20s, 30s, or 40s will be diagnosed with colorectal cancer, and more than 3,600 in these age groups will die from the disease. So that's 49 new cases and 10 deaths per day in people 50. And almost half of these are ages 45 to 49, and thus could potentially have benefited from screening 45. The last topic I'll touch on is appendiceal cancer, as I mentioned earlier, and how its inclusion in rates for colorectal cancer in surveillance data are influencing trends. This slide shows appendiceal cancer incidence rates by age, along with the annual percent change from 1995 to 2012, and then from 2012 to 2016. Incidence has been increasing since the mid-90s after remaining stable previously, largely because of increased detection through imaging. Since 2012, however, there's been a dramatic uptick, especially in those younger than 50. The steep increase in the past 5 years is because of changes in classification for a large proportion of appendiceal cancers that are neuroendocrine tumors, which were formerly referred to as carcinoids. And these represent about 40% of all appendiceal cancers, but about 2/3 of appendiceal cancers in people under 50. In 2010, WHO revised the behavior code for neuroendocrine tumors from borderline malignant, which is not reportable in cancer registries, and thus reportable. And that's why you see this steep rise. And this table shows the influence of appendiceal cancer on colorectal cancer incidence trends by age, APC over the past 5 years, with including appendix in the first column and excluding it in the second column. For all ages combined, rates are stable with the inclusion of appendix, but declining when appendix is excluded. And by age group, the inclusion of appendiceal cancer has the largest influence on trends for early onset disease, because 40% of appendiceal cancers are in this age group, and a disproportionate number, as I mentioned, are neuroendocrine tumors. So even though appendix is very rare, it's having a pretty large impact on trends for colorectal cancer, even for all ages combined. The issue is particularly relevant when comparing trends in early onset colorectal cancer by anatomic subsite, because appendix only influences rates for colon cancer. With the inclusion of appendix shown in the panel on the far left, it appears as though colon cancer rates are increasing 3 times faster than rectal cancer rates, shown on the far right. But in fact, when you exclude appendix, you can see that the rate of increase is similar now in the past 5 data years for colon and rectum. Although most studies of early onset colorectal cancer exclude appendiceal tumors, overall statistics reported by NCI and CDC and ACS as well have included appendiceal cancers. However, the AJCC began classifying appendiceal carcinomas separate from colorectal cancer in 2010, coinciding with the WHO change, because accumulated evidence suggests that these cancers are distinct in histology and clinical characteristics from colorectal cancer. So we excluded appendix from our trends in this report, and going forward, we'll be excluding them not only from trends, but also from colorectal cancer rates. And this is going to begin with Cancer Facts and Figures 2021, which we'll publish in January. We've also been in conversations with NCI about this issue, and they'll be providing SEER rates and trends with and without the inclusion of appendix going forward in their cancer statistics review and in their data sources online. In conclusion, the colorectal cancer burden in the US continues to be highest in Alaska Natives and in the Black community, although the Black-white disparity has begun to narrow because of continued rapid declines in mortality among Blacks of all ages. Progress in reducing incidence is now confined to ages 65 and older, and this, alongside increasing rates in younger age groups, is rapidly shifting the patient population younger. Increasing incidence under 50 is confined to advanced disease, and although the absolute risk before 50 remains low, the burden is substantial and growing, with 49 new cases per day expected to be diagnosed in 2020. Delays in diagnosis that are common among young patients will likely be exacerbated by the coronavirus pandemic, as well as diagnosis in all ages. And finally, future colorectal cancer incidence rates and trends will exclude appendiceal lesions. So although we probably won't know for some time what exposures are causing the increased risk of colorectal cancer, there's a lot that can be done now to save lives. And I've included some of these on this slide. More than half of colorectal cancers are associated with behavioral factors. So encouraging healthier lifestyles is critical, along with more guideline appropriate screening, especially among low income and rural communities. Screening at age 45 has been shown recently to be cost effective, and there's a bulge of cancers in people in their early 50s that could have been detected earlier, or maybe even prevented with widespread screening beginning at 45. Plus, a large proportion of the population should be screened at 40 because of familial risk. And this is certainly even a larger percentage among Blacks and Alaska Natives who have high risk in general. Delays in diagnosis among young patients could be reduced by increasing awareness about symptoms, along with campaigns to destigmatize the disease, which is thought to contribute to a lot of these delays in the initial interaction with the healthcare system. And finally, the oncology community needs to adapt their treatment approach to fit the needs of young patients. Young survivors report lack of information as the biggest gap in their cancer care, and this is an easy problem to solve. I'd like to thank cancer registry staff worldwide for collecting the data that allows all of our research, as well as collaborators on this project. And thank you for your kind attention.
So thank you, Becky. That was really fantastic. We do have some questions in the question and answer box, and we have some time, so be sure to, anything that you can think of that you'd like to ask us, please post it. So do we have any sense, Becky, of what the current screening rate is for 45 to 49-year-old patients?
Yes, it's about 21% in 2018. Up to date, and that's up to date screening prevalence.
Yeah. Do you have I'm just going to have a follow-up question to that. Do you have a sense of how much of that rate is new? In other words, we do have a sense that some adults were getting screened in their 40s for colorectal cancer, and that some of that may have been a function of being at higher risk. But how much do you think this is perhaps attributable to the new recommendations? Do you have any idea?
I'm not, it's really hard to know because the current screening data is only through 2018, and that's when the new guidelines were released. But I was actually a little surprised that it was as high as 21%. And so I think the guidelines, along with hopefully increased awareness about the increased risk, will help increase those rates. So I would say probably a little bit, but I think it'll be really telling what happens with the USPSTF and their new guidelines. So I think we just have to wait and see.
Yeah, well, and we're all hopeful that they will recognize the importance of the data that you've done so much work on, highlighting the fact that the rates today in the mid-40s are where they were 20 years ago in the early 50s. So are the screening rates still being reported by the BRFSS data?
Meaning because of the COVID-19?
No, I think basically, I think the question really pertains, and if it's not, please send us a note saying that we misinterpreted what you were asking. How do we have a sense of, I mean, colorectal cancer screening is a regular part of the interview every other year, every year?
Or I think it's about every other year.
Yeah, yeah. So we always would like to get the BRFSS data a bit more granular, but everybody wants something out of the BRFSS data. So, okay, due to the greater impact of appendiceal cancer, will ACS be doing any research around this cancer, or will cancer.org add it to the list of cancers they provide information and resources for?
I'm not sure, honestly, what is on cancer.org right now. appendiceal cancer. It's a very rare cancer. The rate is about 1 per 100,000 in the general population. So it's actually a bit surprising that it's having such a large impact on, I mean, I was surprised that the overall trend is actually different with and without the inclusion. So it's a rare cancer, and it's really, the increase is really largely due to detection, because the mortality rates are low. Survival is high for most the appendix. So in terms, I can't really speak to the information on cancer.org, but I definitely think it's a good idea to have a suggestion with our web staff and see what's there. I think the important thing to keep in mind is that the rates are going to change going forward. I think this is going to be, we were really excited to hear that NCI was on board in terms of excluding appendix from their colorectal cancer rates, but it is going to cause, you know, a shift, and so you'll have to be careful when you're tracking trends. But I think that's the more important thing, and not to be concerned about a big increase in occurrence of appendiceal cancer, that it's more of a detection and classification issue.
Okay. This next question, and some of you submitted questions to the chat box, and so I'm going to get to those in just one second. But this next question says, do you have any suggestions, or do we have any idea of what we can do about insurance companies not covering colorectal cancer screening before age 50?
I know that our advocacy organization, ACS CAN, is working hard on that issue, and I think a lot of insurers do cover it, and an increasing number. And I'm not sure, Bob, if you might have more information on that.
We don't. We do know that some insurance companies just made the change on their own. And we also have a sense that, you know, some states have legislation in place that may oblige a health plan to cover the current ACS guideline. When we were advocating for these particular laws, we always wanted to be very, very clear that you could not enshrine a particular guideline in the legislation, because that would make it difficult to change to the new one. So we always wanted to stress, you know, whatever the current ACS guidelines were, those would be the ones that would be covered. But it's hard to say. What we do hope for is that the task force will see the logic of the update that we posted in 2018, keeping in mind that, you know, organizations like the ACS and the task force do not schedule their guideline updates to take place in the same year. So one or the other of us is generally always a few years, has a few years of more recent data that underpins their guidelines. So these new guidelines don't so much reflect a difference of opinion in the interpretation of the data. It's just that we had access to different data than they did at the time we updated our guidelines. So there are guidelines. And this next question asks if we know when those guidelines are going to be updated. And my sense is that it very likely would be later this year. Becky, do you have a sense of that as well?
I would say later this year, or maybe even early 2021, just because there may be delays because of the pandemic. I'm not sure.
Could be. And they also had some delays in lung, waiting for the Nelson results to come out. So we're expecting those two sometime within the next 12 months and possibly even sooner. Okay, this is one that's actually relevant to that paper that was published in Cancer Epi Biomarkers and Prevention related to the hotspots. Any progress in identifying contributing factors related to the mortality hotspots reported in 2015?
As I mentioned, in terms of the black-white disparity, a paper that was published in the past year or so by our group found that over half of that disparity was related to insurance, differences in insurance. And so I think it's really access to care and poverty in those areas. And as we know, the income gap is widening. And I would guess that, again, the influence of the pandemic would be to increase that disparity, if anything. So we haven't done any follow-up to that hotspots paper, but a lot of people ask about it. And so I think that will definitely be something that we'll be looking at this year or next year to reevaluate.
Okay. This question relates to appendiceal cancer, and the question is, would Cologuard pick up appendiceal colorectal cancer?
That I do not know. I'm pretty sure, and Bob, you probably know better than I, but I think that sometimes colonoscopy can detect it, but rarely. That's my understanding. Is that correct?
Yes, and I think the answer is no, because it's these are cancers that Cologuard is going to pick up cancers through a stool test, and so that those markers in that blood would have to be in the stool. And I'm not sure that an appendiceal cancer would shed that way.
Mm-hmm.
Yeah. So this question actually is one that is similar to one that I was going to ask you also about what can we do today. Is there any way to track family history and how some of the guidelines for earlier screening is not low enough? The whole family history issue is, I think, very important for early onset colorectal cancer. And it is something that we could be doing right now. Could you say a few words about that?
Yes, and I actually I had that in my final comments, but I was thinking they were too long, so I took it out. But about a third of early onset colorectal cancer is estimated to be related to familial risk. And we know that there is not enough family history taking and updating family history, and not only that, but just acting on the information. There are so many gaps there along the way. And again, for the Black community and Alaska Natives who already have very high risk, certainly those proportions would be larger. So I think there's a critical need to increase awareness among the general public about the importance of knowing your family history and talking to your primary care doctor about it, even if you aren't asked. And I think an informational campaign could really go far in that regard, because if people understood how important family history was in terms of their own personal risk, I think they would act on it more.
Yeah, I think so too. So, Becky, a lot of attention to the Z's, the zebras on the last slide. This is a webinar trick, you know. Can you speak more to the zebras in the last slide about primary care providers and the recommended opportunities?
Sure. So we know that medical school students learn that when they hear hoofbeats, they should think horses and not zebras. And I think that too often primary care doctors are thinking horses, and there needs to be an awareness that the zebras are are out there and increasing. And I I have that top of mind because I actually received an email uh, in March after we were working from home and the pandemic had begun, and it was from a young man in his 20s who was having uh, major symptoms of rectal cancer that I won't go into, but very concerning. And he had contacted his doctor, and he'd been seen actually a year prior, and then the symptoms were worse. And his doctor told him, think horses. And he said to me, what does that mean? And um, so I just think that we should be thinking more about zebras these days for colorectal cancer. And that's why it was in there.
Yeah, that's good. Um, let's see. Um, we have a question, a sort of a personal question about from one of the attendees who was diagnosed with ulcerative colitis. They're 46 and wondering if screening would be recommended. Inflammatory bowel disease is a risk factor for colorectal cancer, but only if it has, is the patient has had it for some duration. Usually a benchmark of that is about 8 years. But certainly at the age of 46, we think you're a candidate for screening right now, and would be screened according to whatever your doctor would recommend or whatever they identify during your examination. So I think the answer is yes. There's a question that says, it appears from the slides that screening has essentially leveled off over the year despite efforts to achieve 80%. In your opinion, what is the cause of this? Now, this is to all panelists, and I don't know if any others of the panelists besides Becky and I would like to answer that. But Becky, do you want to take the first pass and then I'll follow up?
Sure. I would say that, relative to the steep increase during the 2000s, it may look flat, but in fact, screening prevalence continues to inch up. And in fact, there was, a notable increase from 2015 to 2018 in up-to-date screening. So I think we're still making progress, although it's really slowed. And I know the 80% in every community effort is really focusing, and Bob can speak more to this, but really trying to focus on those populations that I pointed out where screening rates still are low, like especially the under age 55 population, and a lot of the rural communities, and the low income communities. So I think, and those are harder to reach. But I think we're still making progress. It's just slowed. And I think we're going to need more targeted efforts to bring it up further. And not sure what you would add to that, Bob.
Well, not a whole lot. I mean, if you look at all the cancer screening in this country, the fact is we pretty much max out at 60 to 70%. And what this really does reflect is not only the absence of a system, and keep in mind these reports are cross-sectional. They're just what the population reports they've done recently. So against that backdrop are many instances where people didn't get screened the time before last, or got screened at a different interval. So the absence of a system, and then some people just require a lot more hand-holding and a lot more persuasion. They also may be distracted, and their doctor may be distracted by other, health conditions, even though those would not disqualify them for screening. So what we really have to do and have to keep working to do is to combine a sense of urgency and importance that as a preventive health commitment, it can make a very, very big difference, in avoiding a premature death and certainly disability. And it's something that should be viewed as of high importance and just a part of your regular preventive care. And, help and support from your health system, your primary care provider, can go a long way to ensure that you do this. So it's, we know these things work, and we just have to, I think, our best opportunity is to be rather relentless about this, and especially in providing and counseling clinicians, that some people just are going to require more work. You can't just say, oh, by the way, you need your colonoscopy and expect that it's going to happen. So one new question. Can you speak to some of the potential birth cohort exposures, early life exposures that may have increased early onset colorectal cancer rates? Any of those, Becky, that you think are particularly promising and ought to be pursued?
Yeah, that's the million-dollar question. I think that dietary exposures are very important for colorectal cancer risk. And so I think those changes in the food supply that have been fairly rapid and began in the mid 1900s will be important to look at, as well as just there's been so many changes, a lot of increase in antibiotic use began around that time. So there's really, that work is all just beginning to understand the microbiome and its influence in both increasing and decreasing risk. So it's really just, I think that's going to take some time to flesh out. But like I said, I think in the meantime, there's so much that could be done now to save lives for everyone, but especially for these young patients, just in reducing delays in diagnosis. There's just a lot of opportunity there to destigmatize the disease, to increase awareness of what are the symptoms, and that young people may have cancer even though they probably don't. So just information is so important.
Yeah, no question about it. This is something that greater responsiveness is at our fingertips, and this is something that we're really trying to promote. One last question is what role will take-home tests, which are social distancing friendly, play in catching up after COVID-19 by risk of stratifying of those most in need of a colonoscopy? It's a really good question. We have, and ACS can have been, working together to try to emphasize that catching up with the backlog of colorectal cancer screening can be done very efficiently with FIT testing. That people who are due for a colonoscopy or about to have their first colonoscopy don't have to view this as not having a colonoscopy as a lifetime decision. It just means that you can be screened with a high sensitivity stool test right now, and that would mean that would measurably reduce the stress that's going to be put on colonoscopy services if everybody tries to catch up. getting a colonoscopy. I think it's a very smart idea. There are some countries where the opportunity for self-sampling for HPV testing for cervical cancer screening is starting to gain some momentum, but on a recent call, they were hoping to overcome their backlog of about 50,000 pap smears that way, but quickly ran into the roadblock of not being able to get swabs, because the swabs are all being purposed for testing patients for infection with the virus. So we are at the top of the hour. I don't think we have any more time to answer the questions you submitted, but we will answer them by email. I'd like to share a huge thank you and gratitude to Rebecca Siegel for generously giving us of her time and her expertise to discuss these colorectal cancer trends, and as well as thank you to the American Cancer Society and the Centers for Disease Control for their support of the National Colorectal Cancer Roundtable. We encourage you all to connect with us on social media and find information about upcoming roundtable webinars and other news. And for more information on today's webinar, email us at nccrt@cancer.org. So thank you all for joining us today, and we hope all of you have a wonderful afternoon. Goodbye.